This is all about fair, and I will focus on one of the letters, not on the findable, not on the accessible, but on the interoperable, and hopefully that makes it more reusable. So interoperability, and it's not something that you have to invent. So I want to talk to you about the semantic unification that we're doing already in ABR in the Netherlands, based on international terminology standards. Fakki will then go on to explain more about the terminology standards and how we're using them. But first let me talk a little bit about what the Semantic Unification project is all about. What we're trying to do is, in the surveillance of ABR, we want to improve the communication between the routine diagnostics that are done in the lab and the surveillance that's being done at the RIVM. Oh, I never know how to pronounce that in English. And so that's one part, and the other part is that we want to have more timely information in our surveillance. So basically we want to move from manual to automated processing, and we want to do away with the steps that are needed to interpret the data that are being sent to the RIVM, and we want to make sure that we understand them directly, so we can have improved healthcare because we have better surveillance, more timely surveillance, and we know what we're talking about. So the project that we set up does this. Basically, if you look at the picture, we take the routine diagnostics from the labs. They all identify microorganisms, the antibiotics resistance. They do their tests, and they send them to the RIVM, and we unify the semantics by using the standard lab terminology codes. And those are, again, based on international standards. So we tried that we started doing that in 2017 with 6 pilot labs. 2 of them are now in production and really have done away with the old way of providing their data for surveillance. 2 more are in the process of doing so over the summer, and 2 are having some problems still that have to be overcome. But in principle it works. So in 2018 we already saw that how we want to do this, and then we said, well, we want to have the front runners. So we had 8 more labs that signed up for implementing this, and just last month we had 15 more labs that started with the nationwide implementation, and the rest of the labs will follow next year. So all the labs at the end of 2020, which is kind of when your projects are starting, will have done, will at least have started participating in the national surveillance based on one national lab code set for antibiotics resistance. So that's something that you can use. If you use routine diagnostic data, or you use data that come from your labs with the local codes embedded in your data set, they will already have the mapping available to do that. What does that mean, semantic unification? Because I'm talking about mapping and things, so let me go back to the basics. There's 4 steps to this. We start with the microorganisms. We then identify what tests are being done, what's the susceptibility, and then we can move on to genetic types of antibiotics resistance. That's still a work in progress. That's not in production yet, but we're moving in that direction. Anyone know this microorganism? It doesn't have a barcode, and it doesn't have a name tag like some of you. Mine is on my jacket, so I don't have a name tag. This is what it could be called. Others call it Klebsiella pneumoniae. Again, English. But also it could be known under a totally different name, Friedlander's bacillus. I'm not sure how many of you knew that actually. I didn't, but I found it in the terminology. So there's a terminology there. If you look up this code, that stands for all those 3 of them, all 3 of these names. So we have one identifier that identifies the name however you spell it. whatever your preference is in shortening it or whatever. But there's one code that's actively maintained with the help of the microbiologists to actually know that we're talking about the same microorganisms. Of course, the question is, how did we identify it? How did we find that bacteria? For example, bioculture from midstream urine. And there's codes for that as well. So you see here a whole list of codes, and that exactly specifies that we identified this bacteria through a culture, and we identify the material, how we, where the material came from, and how we actually obtained the material. So we have loin codes for the tests, we have Snomed CT codes for material topography procedure, and there is a fully worked out material table for the ABR tests that are being performed in the routine diagnostics right now. And the result, of course, will be that number for Klebsiella that we saw earlier, if actually you did find a Klebsiella in a mid-urine sample by culture. So that's step 2. Step 3 is then, what does it say about antibiotic resistance? Nothing. Oh, sorry, I forgot one thing. We are using Loink and Sno-Med, but the Dutch lab code set takes a very specific perspective on which codes are you using where. We could have used the other code for those 3 things that are there. And if you look it up, it actually specifies that it is the exact same thing. But actually, to make it easier and to have a standard format for these codes, we actually say within ABR that this is the way we do this. In fact, we'll go into that a little bit more as well. So we have specific choices. We don't want everybody to start with the name and then look it up in Sno-Med and start with the material, etc. So we have predefined choices within those international terminologies. What does it tell us about ABR? Well, we have to do the tests, susceptibility tests, and those are coded as well. So we have different codes for all the tests that you can think of, and if there's a new test that comes along, then we can add those codes as well. And usually they will have been added by someone else around the world already, because you're probably not the first one to do that test. And of course the test results can vary in millimeters, MIC values, etc. And the conclusion itself can also be represented. So depending on what type of test you do, the units of measure will be different. And of course we then go on to genetic typing through PCRs, whole genome sequencing or next generation sequencing, and then we can adopt a standard of how to communicate that, either on a typing level or on the detailed level. I'm not sure where we will go in that direction, in which direction we will go there, but that's something that we're working on right now. So that's already being done. And why is this important? In the short term for us, it's because we end up with near real-time surveillance of bacteria that can be, and that information can be carried back to the individual institutions, to the individual labs, to see how did this happen, and what is it that we need to do to stop any further spreading of the bacteria. And of course, there's other ways. So basically, it's being funded through the ABR program from the ministry, and it really is about better prevention and better interventions at the local level. And that was also in my first slide, where I said, well, we get the data from the labs, but we give the data back so that they can act upon it and really take the right interventions to make it happen. In the longer term, it's not just about antibiotics resistance. We're using the Dutch lab code set, which also implies that it's broader. It's for most of the lab tests that are being carried out in a clinical setting. So that's where we can use this, and we can have comparable results across the patient journey. We actually can do a lot more things there. So we understand, no matter where the test comes from, we understand what test it was, what the outcome was, and how to interpret it in the specific clinical setting. So that's why we're doing this. And this helps you, of course, in in making ABR data more fair at the eye level of interoperability. And how that can be done, that's for Feike to explain to you. Yep.
Thank you. Right, so my name is Feike Hielkema. I work at NICTIS as a terminology expert, and I also do functional maintenance on the Dutch labcode set. And I'll tell you something about semantic interoperability specifically for laboratory data in more detail. So, semantic operability, the key idea here is it's not about what you say, it's not about the words you use, it's about what you mean to convey. So, for instance, there's a concept here, pneumonia due to cytomegalovirus. Some nasty tiny organism that can make you feel very ill. You can express this in Dutch by different ways. You can say pneumonie or you can say longontsteking, which sounds entirely different but means the exact same thing. Or you can say cytomegalovirus, but as a doctor in a hurry you will probably just write CMV. Different terms can express the same meaning, and different meanings can be conveyed, also be expressed by the same term. So we use terminology standards to register the intended meaning instead of the terms used. Now, internationally the situation for laboratories, there are a number of international terminology systems, and the most important are these three: LOINC for question, Sno-Med for the answer, for the result, and UCOM for units of measurement. LOINC for the question. So LOINC is a system that's used in a number of countries. It contains about 75,000 codes. And those codes all concern clinical or laboratory tests. So there are things like blood pressure measurement or body height, but mostly also things like blood glucose measurement, and of course many organism cultures. LOINC can also be used, it can be used to both note the test you're ordering. So if you want to know whether a patient has a salmonella infection, there's a code for that. The same code can be used for registering that the test was indeed performed. And it also contains some codes for the results. Sno-Med is a somewhat larger terminology system. It's broader in scope. It contains more than 300,000 codes. And these codes are meant to convey different kinds of information. The largest branch is disorders and clinical findings. So things like patient has hypertension, patient has a fever, patient has a cytomegalovirus infection, etc., etc. There's another large branch for all kinds of medical procedures. Things like blood pressure management, yes, but also things like operations. And then there are branches that are used to convey these main hierarchies. So there's a large organism branch, which contains cytomegalovirus. There's a large branch of anatomical structures, because if you want to define what a pneumonia is, you need to know there's something called a lung, and that's the bit that's affected. And so on. There's a branch of medication, and so on and so on. Now, the key strength of Sno-Med is that it has defining relationships. So relations between different kinds of concepts that tell you something, or tell the computer something more about what that concept is. So the concept pneumonia is more than just a number and a set of names that belongs to it. It has relations saying, actually, this is a type of infection. The morphologic changes it makes are that it's a consolidation and an inflammation. And this happens specifically in the lung. And it may be caused by this particular virus and so on. Inge, my colleague, is going to show you a bit more about that later. And she's also going to give a nice demo of the research questions you can ask and answer using Sno-Med. Finally, I mentioned UCOM. probably less relevant here, but for clinical chemistry labs important. It's a way to define the units you're measuring in. So if you're measuring a blood glucose concentration, it is very important to know whether you've been measuring in millimole per liter or in milligram per deciliter. These are both units in use, though admittedly one of them only in the States. But it's such a beautiful example. If you measure 20, millimole per liter is pretty high, sky high, probably a good reason to take some insulin. 20 milligram per deciliter is so very low you've probably already slipped into a coma. So you don't want your doctor to start administering insulin then. It would finish you off. Which is why it's important to use a standardized unit of measurement. Right. Now, what I've mentioned so far are all international standards. And they are huge, as you saw. 75,000 laboratory tests, more than 300,000 Sno-Med codes. You don't just hand that to a lab analyst or a doctor saying, well, just pick your code, because that will lead to anarchy. So what we've done in the Netherlands is create subsets. Subsets that say, well, these things are being done in the Netherlands, and that's how you register them. One of the first subsets we made for a lab is a reference set of microorganisms. It contains more than 300 Sno-Med concepts, the identifier, the English name, Dutch translations, which is basically it. It was compiled by the Scientific Association of Medical Microbiology, and it mainly contains bacteria and fungi at present. Second, the Dutch labcode set. Now this is a national set consisting of LOINC concepts. So it's a subset of LOINC, about 10% of it, which have been translated into Dutch and have been enriched with more information. So there's a link to the specimen that a test can be conducted in, and that specimen is registered using Sno-Med. And there's also a link to the results that may come out of the test. For instance, if it's a culture, then the result would be the microorganism set, with which you can specify the organisms that you actually detected, that you managed to grow. On the other hand, if it's a quantitative test, such as a blood glucose measurement, you use EUCOM to specify the unit. The first version, though it was long in the making, was published 2 months ago, which we are very happy with. In the future, we'd also like to link it with the procedure thesaurus, which is worked on in Dutch hospital data, and to link it with the National GP Reference Table for Laboratory Tests, also known as NRG Tabel 45. Now, there are a number of advantages to the lab code set. Normally I give this presentation to laboratory analysts who are trying to convince that they should map to it, right? So why should they map to it? Well, you can exchange your data without all those local mapping tables they're maintaining now. At the moment, if you're in a lab, you have your local table. Every single other lab you exchange with, you have to maintain your mapping table. Every hospital you exchange data with, you have to maintain your mapping table. It's a lot of work. If everyone maps to the Dutch lab code set, it's going to save a lot of work. It makes ordering and reporting rather more transparent, and it's much easier to aggregate, to compare your data to that of other laboratories. Or if you're a researcher, if you have data from different laboratories, it will make it easier to merge those. It will also be easier for vendors to manage. And, well, last certainly not least, we have been careful to use only international codes. So if you want, yes, thank you. If you want to take your data across the border, if you want to compare it with things across the border, that is much easier using the lab code set. If you want to explore the contents, that's perfectly possible. There is a browser online. You do not need to log in. It's publicly available, and you can simply search here for the codes that are already in the lab code set. So here's a screenshot of hemoglobin A1 results, The topmost bit is all the tests that match with your search term. The middle is all the information that is in LOINC about the result you've selected, including the Dutch translation. And the lowest pane contains information the information that we enriched it with in the lab code set. So the Snomed material that we've mapped it to, and also the UCOM unit in this case, which it is registered. Or if it's an ordinal test, something that says positive or negative, there will be an ordinal result list there, also mapped to Snomed. Then the third item, Robert mentioned it briefly as well, there's a material table. So one of the biggest problems in interoperability is that generally different user groups do not need information at the same level of granularity. They don't need the same level of detail. Here's very much a case in point. We have two user groups here, the clinical chemistry and the medical microbiology. And they differ they have a difference of opinion about how granular, how specific the material concept, the system should be. So the clinical chemistry have told us, well, we want to know whether it's blood or urine, yes, but that's all. We don't need any more detail. Whereas the microbiologists say, no, yes, blood, okay, all right, I also want to know where it came from. Or urine, well, I want to know whether it's urine from the urethra or urine from the bladder or the kidney. This is important. So in the first case, a LOINC test usually contains, for instance here, if you look at system, you can see it's blood. So the LOINC test already specifies sort of the system it's in. But for medical microbiology, that's not enough. They want to know where it came from. If you would just include all that information in the LOINC code, you would then multiply the number of LOINC codes you were using by about 100 probably. We decided not to go there and instead create a separate table so we could combine that with the test. So you could say, well, first you have one code for the test and you have another code for the material you've done it in. And that combination tells you exactly what you did. It does complicate matters a bit for laboratories. They need to map their materials as well to a set of LOINC codes, taking various things into account. The basic substance, is it urine, is it blood, is it serum, is it hair, whatever. The topography, where did it come from? Is it the arm, the leg, the bladder, etc. The morphology, if it's a wound or an abscess or a fistula, possibly a source object if it came from a catheter tip, and the collection procedure. Basically, they all map to Sno-Med codes in specific hierarchies. That's quite a difficult job, and to guide them, we've created a material table. So, as Robert said, this table restricts you to a limited number of choices. Not because those choices are really all you have available, but because those choices are the most frequently made. So, for instance, if you want to register that you've got a pus specimen, there is a predefined concept in Sno-Med for a pus specimen. There's probably a predefined concept for pus swab. There is not a predefined concept for a pus swab of an abscess of the back. It's just way too specific. Using the material table, you can, however, specify exactly that, because you select the substance, the topography, the morphology, and the procedure all separately. You can also leave axis empty. In this case, we've left the object empty because there's no source object there. But you could also say, well, it's not from an abscess, it's just a pus swab of the back, so we'll leave that empty too. Choosing these different codes and combining them in the correct manner with the correct properties gives you an expression that's actually equivalent, means the exact same thing as the predefined specimen concept. So you can use those in conjunction. If some other data set uses the predefined specimen code and you use this expression, it means the same thing, and you can there is software that will detect that it is the same thing. So it is, in fact, interoperable. So, if you have a data set and you want to map it to laboratory data, to laboratory terminology standards, you take your test, which presumably in this instance will be antimicrobial resistance test, and you map them to LOINC concepts in a lab code set. If you do that, just make sure that you pay attention to all the axes of a LOINC concept. Don't just look at the component, but make sure that the system matches, that you're not mapping a blood test to a urine test. Make sure that the scale matches. If you've got a quantitative test, you can't map it to an ordinal test because they're very different things, and so on. If you have a list of microorganisms, map them to the Snomed concepts in the microorganism reference set. If you have a list of materials, map them to the material table. Now, it is extremely likely that during this process you will detect that our code in Snomed but not in the microorganism ref set or in the material table, or that you run into questions. If you have any questions, any change requests, send them to this email and we will have a look. So, I'm almost done. These systems being based on international terminology systems means there are some license requirements. Sno-Med, you need a license to use Sno-Med. In the Netherlands, that license is free, but you still need to request it before you can download it at that address. LOINC does not actually require a license. It's more like a user agreement, which you need to sign online. It's basically, when you use LOINC, you need to state that you're using it. You can request access to LOINC for free. The Dutch lab code set being based on LOINC and Sno-Med, you will need to apply for Sno-Med license, and you will need to make sure you have access to LOINC. But when you do, you can download it, same place as you can download the Dutch Sno-Med edition. Finally, the material table, also used based on Sno-Med, so also requires a Sno-Med license. But there's a pilot version online, and I hope that that the official version will come online, in fact, next week. Right. This site tells you more, unfortunately in Dutch, about antimicrobial resistance, the project in the Netherlands, and the standards that are being used. Then there's the labcode set browser, which I showed you just now. There's a link here as well. And there's some advice for how to extract a reference set, such as the microorganism reference set from Sno-Med. But again, if you have any questions about that, look at the site of NICTIS or send us an email, and we will be, we will oblige.
Your question is when will all labs be participating in semantic unification? More or less. For microbiology, it's clear. We have a timeline that says that in 2020 all medical microbiology labs will be participating. Whether they're already done remains to be seen. Some of them might take a little bit longer, but at least in 2020 we want to have attract the remaining hospitals that are not participating, or the remaining labs, I should say. That's for the routine diagnostics. It's not for the genetic typing. That will also be carried out quickly, but I'm not sure what the timeline of that will be, because that's the pilot that we're still working on a little bit. And the typing will only be for the two things that we currently do typing on within the RIVM, so the MRSA and the CPE. So typing will take a little bit longer before all typing that's done within the AMR field is actually standardized and everyone will participate. So for AMR, it's fairly clear. So 2020, people should have been done the mapping, whether they're live in terms of providing their data to the IDVM. There could be some technical glitches there, but the mapping will have been done. So if within the context of this call, you can use that mapping for your project proposal. That should be possible. And in broader terms, for the Dutch lab code set, that remains to be seen how quickly that comes live. We now have, luckily, for 2 months, we have say the 80% of the most used clinical chemistry tests also coded. When and how the uptake will be, that remains to be seen, and that's something that's part of discussion with the ministry and with the Informatieberaadszorg, who has said, well, yes, we want to do this, but we don't have a timeline yet. Any other questions?
And how about, well, in the scope of One Health, how about veterinary labs and maybe even like commercial labs who are in Germany doing diagnostics for the Dutch patients, is for human labs as well as for veterinary labs. So what about that?
Actually, I don't have an answer. Of course, you can still do the same mapping as Fakia explained, just using the codes there. The problem with veterinary labs is that Sno-Med is not fully equipped to deal with veterinary medicine, I think.
It's true in that all the veterinary content was moved to a separate module. However, many of those lab tests, or at least the results, I mean, the microorganism isn't going to change. So that should, at that level, it might well work.
But in general, we are not including veterinary labs in the current project. So they will have to, and they can use the same methodology and the same tools that have been developed to actually do the mapping. And the mapping itself, it's not that big of a job. I mean, it seems quite overwhelming if you look at the 300,000 terms, but in practice, it's about, well, I think we budgeted about 10 man-days of work to do the whole mapping for ABR. So that's only 10 man-days. So if you have to do it, you can budget it and ask for funding to actually make it happen.
Well, the thing to remember is you don't need to map to the whole of the code set. You just need to map your data to the code set. That should probably be a subset.
So it's up to the researcher to use it. But can you make a connection with the call we are now having? Reuse data. So at which stage of preparing your project or performing your project will you start using Sno-Med, the lab code set?
Right, so we already established that this call does not involve the gathering of data. Otherwise, I would say the minute you gather it, right? But I will assume someone has a data set from somewhere or a set of data sets and they want to get working with them. I'd say almost the starting point is to look what kind of data is there and which bits are suitable to map to some kind of open standard. And if there are microorganisms in there, if there are lab tests in there, if there are outcomes in there, then look to these systems that we've mentioned. On the other hand, if you've got burger services numbers there, or well, no, you should map those all, sorry. If you've got locations there, you should use some other standard like geonames or whatever. But yes, so the connection with this call is that we would expect you to take a data set and add meaning to it by adding these metadata which refer to these particular terminology systems and thus achieve some semantic interoperability.